majestic going on. Class guy. Nobody from my group is here.
Good afternoon, everyone.
Good afternoon. Please, we'll be starting in the next 4 minutes. That's 2:05. Please hold on.
Yeah. Brother, I'm waiting for
Hello, is anyone talking?
Yeah, I'm here. Please, we'll be starting now. So welcome, good afternoon, everyone. If you can hear me, if there are other people that are not here from your group, you can also inform them before we start. I'll be sharing the attendance any moment from now, but I would like to share some announcements before we move on. So concerning the list and the grouping, I received complaints yesterday, some complaints that some people were having issues that their coursework wasn't marked, and some were even complaining that they didn't submit, like they submitted to their coordinators, but it didn't reach me. And also there are some issues that I saw that some of you didn't check your this thing, your coursework. I made some comments on them. I don't know. I spent a lot of time doing that, and some of you didn't check to see some mistakes that you have done. Please, if for your group, every participant of every member of the group is supposed to check for the mistakes that they have done. I made some comments. You see that I highlighted some words. When you click on the highlight, you see the comments that I made on it. So please check on it so that next time you can also improve on that. I noticed that a lot of people didn't even check the comments I made, and some people didn't even check the scores or any other thing that the scores I wrote them on watermark. And also, I would like to make something clear here. When I was checking the coursework, somebody wrote FAMSA. I was like, God, this is a NiMSA program, please, not IFMAC, not FAMSA. It's NiMSA Nigeria. Please take note of that. So, and that's the major thing that I wanted to note. And also for the second phase of the training, and we say first phase and second phase, please, because we say second phase of the training, it will be more engaging. Please, every person is supposed to be very active. Our attendance from this time would be very strict. Apart from that, and the attendance, the scores for the attendance will be ready. Most likely this week. So you see your scores for your attendance. Those that don't attend sessions will catch them there. Those that do attend, so also know about that. So please, from now on, please, let's get serious. The groupings, I would like to fix any issue. So please, if you're having any problem, whether I don't like your group or your coursework is having any issue or any other thing, please, I don't want to form groups and share these topics and somebody is telling me that he doesn't see that this thing is missing or any other thing. I don't want to receive any complaint again. So please, before the end of today, like after this program, if you have any complaint, I don't know, any complaint that you have that needs to be fixed, please let me know about it. We don't want to start having some funny issues as we are going. Please, those that are having issues concerning the group that they don't like their groups or any other thing, I've adjusted those things. Those that I said that they didn't see their scores in the last coursework, they contacted me. I've repaired everything. So please, if there is anything that you're having issues with, please let me know on time. I don't want to come and be when we are in the middle of the training, you are telling me that your name is not on a list or anything again like that. Please fix everything now. So I'll be sending the attendance form now. So please ensure that you fill it before we move on. Have you seen it? Please just fill it quickly before we move on. Tahaf is raising up his hands. Please. What is it?
Good afternoon, sir. Sorry, we spoke about coursework being marked. If our coursework were marked, they were not returned to me. I'm the group leader for SCOPI Group 6. I didn't see it. If there's a new grouping formula, I've not been communicated. I just saw something on Telegram and I didn't quite comprehend what that was. So I think the information is not being well communicated to some of us. So I think we did 2 coursework. I've not received anyone that was marked and brought back to me. I submitted to my group leader, but I've not seen it. So I don't know how we're doing it.
Wow. Please, and for all groups, I've marked it. Like there is a link I sent. I can't send it here now again. Just check Telegram. I sent some links. It's on Google Drive. That's where all of them are. It's on Google Drive. Just check your group, check your standing committee. Then I made them in group. You see score, this number. Everyone has his own number, that's his own number. And there was someone that submitted without grouping code. If you submit without grouping code, please let me know. I think there's only one group, one person that didn't submit, one group that didn't submit without any group code or any other thing. But everything that I have are rectified. So please go and check the list. Check it on Google Drive. You see the documents, your coursework that was marked. It was only the first one, please. The second one has not been marked. So it's first
All right.
coursework and the third one that has been
Okay.
worked on. So please
Okay, sir.
go on Telegram. You see the drive. Check it. For the third coursework, is on a spreadsheet. You see the scores there. But for
Okay.
please sign in, not sign out. But for the that other one that you wrote, I just made
Yes, sir.
comment on it, and the
Okay.
watermark is basically your score. So you see the watermark and you also see the comments. Just go.
Okay.
Don't. Some people may just check the document and they will not scroll down to check any other highlights. Please check the entire document. You see everything that I
Okay.
highlighted bit by bit. So you see any mistake that you are making, so that you won't make it in the
All right, sir.
next ones.
So you spoke about regrouping. So how am I going to understand what you posted in the Telegram with respect to the new groups?
Just check the things what did the pin?
Okay.
Just check the pin messages. Just check
All right,
all
sir.
of them.
Okay.
You see
Thank
the
you,
new
sir.
grouping list also. It's also written there.
Okay.
Please, who
Okay, thank you
again
very much, sir.
has a question?
All right, I have a question, sir.
Okay.
Yeah, I think my group was changed. So maybe will I maintain the other group or the new group? I mean, with respect to the attendance.
With respect to attendance, I don't get. Everyone has been like, we have regrouped you, not based
Okay.
on attendance. It was based on the groups we have in your own standing committee.
No,
That was
I'm
how
not
they
talking
regrouped.
about that. No, like before I was 05 and now it's 01. So should I maintain the 05 or 01? That's the point.
Okay, no, the second one, please.
Okay. All right, thank you.
Yeah, you're welcome. So please, that's I think okay, another person is still raising. Please, if Zaid, this is Zaid.
Yes, sir.
What's your
Good
problem?
afternoon.
Good afternoon.
The regrouping, is it apart from the first regrouping you did, was it a second one or just that first one?
I don't know how first and second. There is like list of successful people that moved to the second phase. That's the new grouping I'm talking about. Not any other grouping that came. There's no any grouping that came after that. So that's the latest, that's the recent grouping I'm talking about.
Okay, let me go through it. Okay. One more thing, sir. Please, can I join the class via the YouTube link?
Yeah, you can join, please.
Okay, thank you.
So the last person should ask before we start, please, is Eke Samuel.
Yeah, I'm the one. I just asked the question now.
Okay, then please drop
Yes,
down
sir.
your hands.
Okay, thank you.
Okay, Dr. Ezenwa, I don't know if you are here. I think I saw his message that is.
Hi, good afternoon. I don't know if I could be heard.
Yeah, we can hear you, sir.
Okay, I'll just.
Okay, I don't know if I can still be heard. I was just trying to listen in on the discussion and allow you guys to really sort out what is it. So before I could come in and start what I have. So I really have a few. It's not this healthcare. I don't know what. So once if you say it's okay for me to start, I could go ahead and start sharing.
Yes, you can start.
Slide.
You can start, sir.
Okay, that's fine. So I'll go ahead and just share. So just before I start sharing, I just wanted to make a few comments that this is actually a big one. And the thing with health policy is that we could talk about it all day. Sorry, just excuse me 1 second. So, like I was saying, sorry for that interruption, is that we could talk about this about for so long, and the thing about it is that there are so many dynamics to health policy formulation, and I know a lot of people will be saying, oh, okay, it's not important, and why do we really need to talk about this policy? Why do we've known about policy? So I'm going to start sharing and then subsequently you get to where I'm coming from and see why I'm actually saying what I'm going to share as we continue. So just as a matter of introduction again, my name is Ezenwa Emmanuel, and I'm one of the national clinical mentors and work for the CDC program, HIV Clinical Mentorship Program. Is a program that is focused on providing care and improving quality of care for HIV clients who are currently receiving treatment in Nigeria. So it's not we may not see it as something big because some of us are still, I don't know if I'm speaking to only medical students.
Yes, sir. We are all medical students.
Okay, fine. So, but when you come out and you join us in public health, it's going to make a whole lot of sense when we start going to where I'm heading to now. So I'll start sharing the slides so that we could, feel free to stop me anytime and ask your questions. I will oblige you and we'll go. I don't know if you're seeing my slides and I'm putting them in slideshow.
Yes, you can see it, sir.
Okay, fine. So I'll go ahead. So good afternoon once again and welcome. So I'll just go straight to what is health policy. So before I start, I just want to give a background story. So in my medical school days, we go for lectures. That was second year, third year. We go for lectures, but then there was no posting, right? It was a preclinical class. And I think somebody is screeching something on the screen. So it was a preclinical class, and all what we did was we wanted to see. So at a point, they write attendance, but some people felt the lectures were not helping and stayed back at home and started reading on their own. And that really affected the morale of some of the lecturers. Imagine a class of 130 something, you come to the class and you're seeing like
We can't hear you, sir. Hello, sir. We can't hear you. Sorry, I think he's having network issues. He's joining in now. No, he's joining in now. Sorry. His network issues. I think he wants to log in back again.
hello. Sorry, I think I lost you guys for a minute. I don't know if you could hear me now. Somebody disabled the host sharing. I don't know what's the problem.
Yeah, we can hear you. Sorry.
It's
No,
still
you.
disabled.
Wow.
Okay. Okay. I think I can share now. Sorry about it. I don't know. I'm still in Nigeria, so still some of these network issues just crop out at one point or another. Okay, so like I was saying, a health policy. I don't know if I'm being heard clearly now, and you can see my slides.
We can hear you clearly, sir.
Okay, so I think somebody's still writing on the screen again. So health policy by the WHO defines that decisions, plans, and actions that are undertaken to achieve specific healthcare goals within a society, right? And then public policy is what government. Somebody is scratching on the screen. I don't know who is doing that. Public policy is what governments decide to do or not to do, and their explanations for their outcomes of those some decisions. This is in a civilized world where people just make policies. Sometimes we've seen in our country where people just wake up, do it, make policies, and there is no rationale for those policies except for maybe personal gain or religious undertone or ethnic undertone or just for selfish reasons or financial gains. So we keep wondering what's going on. Why are you making these decisions? So before you can make a public policy, it is what you decide to do. And there must be an explanation for the outcomes and the reasons for those decisions. And health policy also defines a clear vision for the future. So if you want to achieve something in a health sector, you have to have a policy and that policy must align with the vision, and it has to establish targets and points of reference, both for short and medium long term. You know, sometimes health policy sounds as if it's off what we are used to in our medicine and surgery lectures. But I can tell you that everything around you is a policy. You come to school, they tell you must be at school before 8, and then lectures start at 8 and they end at 4. That's a policy. You have to come, you have to wear, some schools adopt a dressing code for their students. You cannot wear below the knee, you cannot wear sleeveless. Those are all policies. And some people say, oh, you must have attendance at least 75%. These are all policies. But what is the aim of those policies? I think that's one thing you must take away from this our discussion. And health policy has to be aspirational. Where are we heading to? Why are we doing this? And it has to clarify priorities. We want medical students to be at school before 8 a.m. so that they will not be late for classes. That's a priority. Establish roles and expectations for different groups, whether doctors, nurses, or administrators. Sometimes the roles are not defined. What am I supposed to do? You know, there has been this struggle among the medical and the paramedics in the healthcare sector. And the discussion has always been, it seems as if some people think the doctors are taking their role. Why some people think these people should not be doing this. Doctor thinks I'm supposed to prescribe. The pharmacist says I'm also supposed to prescribe. I'm a pharmacist. So pharmacists say I'm supposed to import drugs. Doctors say I'm also licensed to do that. So when you have a healthcare policy that carefully delineates duties and roles and what you're expected to do, it removes room for gray areas and confusion. And that's why they push for a lot of policies and acts so that nobody will say, this rule is not favoring me. I'm not doing this. I don't know what I'm expected to do. These policies make it very clear. Now, it also builds a consensus among the different participants, both in the health system and the community. Now I've known my role. I know what I'm supposed to do. Everybody comes together. When I was reading through your brief for this healthcare policy and what you expected by the standing committee, it was quite interesting. I know the pros and cons, that was what you assigned me. But then I looked at the objectives, understanding, I looked at the objectives again, what I'm expected and what I'm supposed to do today. So, and one of the things I saw was understanding the processes of making policy, right? And stakeholder engagement and implementation. I think there was a slide I actually omitted. Who do you actually need? But I'm going to just mention it. And then evaluate and critique our national health policies. I wrote a 3,000 words on just this alone. And like I said at the beginning, health policy is really not easy when you start talking about it. We can talk about it for hours on ending, trying to critique each and every aspect of our healthcare policy in Nigeria. So when you have policies that are geared towards having building a consensus, then you have a free flow of outcome. And don't forget, when you have a good policy, service delivery is smooth. There's always the goal of the healthcare is that every single person received healthcare that is standard, effective, and has easy access to. So when we have policies that work that way, we understand it. So this Howlett and Ramish model of healthcare policy making process. First thing is agenda setting. What is it on the table? What do you want to achieve? The second one is policy formulation. Now we've done this. We now draft a formula. Third one is you now make a decision, right? Who is writing on the screen again? Implementation and then evaluation. So to identify the problem and agenda setting, before I will start, I'll say this is the most politicized aspect of the agenda and the 5 processes. This is where you have to do the town hall meetings, the stakeholder debate, stakeholder consultation, all the things you need to do. This is where it starts. Identify who needs to be on the team. This is where you see people shouting, they were not carried along. They made this policy on this. They were not carried along. They made policy for this one. Students were not there. The lecturers were not there. Some people are protesting. This is the most, for me, it is the most storming and most politicized stage. Everybody wants to be a part of it. Even the gate man feels he's part of the policy on what goes on in the hospital and how much doctors should be paid. It will surprise you. And they'll be busy shouting and talking about it. But at the end, you have to check, what do you want to achieve? What's the agenda? You now know who you're bringing in. So this addresses what is happening and why it is an issue. So you want to have a healthcare policy in a place, and the policy is about people cannot pay for their bills. That is a problem. You have a town hall debate. Why are people not paying? There's poverty, the poverty index, there's unemployment. What can government do? Well, government can start by subsidizing. Okay, we put a subsidy policy. Government can start by, so if your bill is 10,000 naira, you now get to pay 1,000. That's 10%. That's how NHIS came along. So government, you have to pay more healthcare workers, employ more people. These are things that will now be adopted in the policy. And then who are supposed to be there? You need the legislative people to come in so that they can pass this bill at the House of Assembly. We need people who are going to regulate this policy. So MDCN, MDCAN, Nursing Council, these are all people. You need judicial officers that are versed in healthcare policies to be there. And then you have other institutions like the teaching hospitals, the primary healthcare centers that are going to be responsible, the finance body, the statisticians. It will be funny, you need a statistician. You need the Nigerian Bureau of Statistics to come and help you because they need to tell you numbers. So let's say you want to pay healthcare workers and there are 100 healthcare workers to pay. And the statistician is saying, well, first you have to know how many are they, right? Where are they distributed? He will give you that. How much do we need to pay? How much are we paying? What's the world recommended standard? How much do we need to add on what we are doing? What are we expecting to achieve when we add this money? Can our budget carry it? Is it meeting the 15% that was recommended? I don't know if everybody's following.
Yes, we are. So.
I think I really want to hear more people instead of just.
Yes, sir. We're following.
Okay, that's fine. So these are things you need to do. And at this stage, this is where you need to mobilize resources. Remember, I told you, you see the CBN governor coming in, you see the finance minister, minister of state, National Bureau of Statistics, financial commitment, personnel, MDC and consultants. It's a whole wide thing that happens at this stage. And then the number starts going down. Screen is frozen. So we now come to formulation and adoption. Now, depending on the nature of the policy, this could involve a new law or an executive order. When we've done all these our town hall meetings, put all the statistics, committed resources, make estimated budgets, make a plan, 5-year plan. Year 1, this was going to happen. By year 2, this was going to happen. We expected to have implemented 40% of this by December, 60% by January next year. And then by December next year, we must have done 100% and reevaluated our efforts. After we've done all those things, they write it down, bring it to the National Assembly, debate on it, make more noise on it, sorry, not noise, debate, consult more people, remove things, add things, clarify some sentences, make some sentences clear. Why are we saying healthcare worker here? Why are we not saying medical practitioner? Why do we have to say doctor here? Why are we not saying healthcare workers? You know, all those little fine minor details must have been done at that point. And then it is passed at both the lower house and the upper house. That lower house, the House of Reps, and then the bigger, the green chamber, so to speak, the Senate. They call, by the way, they call the lower chamber the red chamber. So when you have adopted it at both houses, they now pass it into law. But before it could be adopted and formulated, the president now signs. It becomes an act that is binding on everybody. Now, to implement this policy, what does implementation involve? Moving forward, taking action. Now the president has signed. They scale it down. What should we do? CMDs now start writing memos, posting all along and everywhere. I think somebody's mic is on. Posting it all along and everywhere, saying now going forward, the policy is that every patient that comes must pay 50% deposit down. It becomes a policy. Everybody starts adopting it. HOD will now say, I don't know if any of us have seen, sometimes you go to HOD office, you see a circular that came from maybe the CMD or the dean, you now see attention, heads of units and heads of, I don't know if anybody have seen something like that, maybe stumbled on it in one office or another.
Yes, I've seen.
Yeah, so you see for attention, so person, attention, HOD, SCOPI, so thing, you know, you see somebody minute on it, maybe handwritten. I've seen it happening a lot in government offices. They are pasted all around. Everybody's, oh, this is now the policy going forward, right? Then this is taking action. This is the implementation phase. Then the next phase is, this is where the problem comes in. How do we know that this thing we've implemented is working? We evaluate it. Do we not? So how do we know students are learning? We do a quiz, we gauge, oh, a lot of people failed. Some people passed. People that passed in question 1. I don't know if we do that in medical school. Maybe when I started international exams and interacting with people from other countries, I started realizing that there are a lot that needs to change in medical education in Nigeria. That includes asking questions. Why did students fail a particular question? Why did they, and short, some of the times we've traveled, and if people fail a particular question, they just remove it and add it for everybody and judge us based on what is remaining. They will say, no, people failed here. So they have to go back, reevaluate the question, give feedback and say, okay, the trainers, you people didn't do well here. I think most of the students failed. What do we need to do? Why do you think people failed here? So they have a feedback that is given to everybody. So you evaluate the policy, examine the efficacy of that policy. Did this policy work? Now that we've said every single person, oh, don't worry, once I'm done, Margaret, I'll answer your question. Now that we've said every single person must pay deposit of 50,000 naira, remember the aim was to make sure everybody, 50% of the deposit fee. Now, we want everybody to access healthcare. After we've made this policy, did it improve access to healthcare? Yes or no? Then we'll bring data. And to do this evaluation, you have to look at the impact, you have to look at the process, you look at the cost-benefit analysis. And the impact focuses on what changed after the introduction. What changes? What did we notice after we introduced this? What did not change? What happened we did not know? We also call it an unexpected outcome. So let's say, for example, we told everybody to start paying deposit of 50%. Some people will now say, you know what, Nigerians can be fun. They'll just come and deposit only 50% and say, that's the only money I have. But initially, when they were saying must pay everything, they paid everything. So it's an unintended outcome we did not know was going to happen. Now we've seen it. Are we going to revise this? So we evaluate it. And we look at the process evaluations. Okay, we consider the implementation of a policy or program and determine the procedure. Now you've told everybody to pay 50% of deposit fee. How do they pay it? Is it transfer? Is it POS? Is it cash? Do they need to go to Sokoto, pay money, go to Oka, collect receipt, go to Lagos, print it, and then bring it back to Abuja? These are things we see all the time in our policy evaluation. It happens all the time in Nigeria. Nobody asks those questions. So these are stages of implementation. And they have to be detailed and descriptive accounts of implementation, including the goals, who is involved, the level of training we gave those people that are doing this, the number of clients who we have served, and the changes to the program. But in addition to this, you also need feedback from the people that received the service. Because you can implement a policy and think that what you did made a lot of sense, but it didn't make a lot of sense. So after an exam, students have failed, students have passed. This particular question was hard. This particular question was not hard. You now give students, imagine if they start after MB, they give everybody a form in the hall and say, fill this form and check if this lecturer should continue teaching you. Did he teach you well? Do you think you understood? I'm sure some of our lecturers may not come back again. I'm very sure, right? Seems all the people I have here. Since all the people I have here are lecturers.
Yes, so
Okay, some of them are planning to be lecturers. Okay, so that's funny. So when you now also give that feedback and evaluate, the faculty can see, I've seen it happen in some of the courses I took. We had a tutor, but when we were done, we felt we didn't learn much, you know? We didn't learn so much of what we were doing, but then at the end, people said that they felt they could have engaged better. He could have given more examples. He could have had a more broken down detail of some of these things that will enable the course. Guess what? The next time we came to take the part 2 of the course, we didn't see him. They brought somebody else from India, and the guy was very good. So at a point, we felt bad. Well, wait, maybe, are you sure it's not this thing some of us feel though? But that is how processes are evaluated. You can improve or you could change. So our national, I think I need to close this. So national healthcare policy for Nigeria. Now we are back home. The first policy was actually launched in 1988. Now national healthcare policy. Whatever thing you're seeing that is happening after that is an improvement on the 1988 healthcare policy and strategy. And it was the first comprehensive and then revised in 2004. I think the last one that was done was 2016. I don't know if another one has been done again. Now, the vision was universal health coverage for all Nigerians, UHC, right? The mission, I did not remove a single word from this. The mission was to provide stakeholders in health with a comprehensive framework for harnessing all resources for healthcare development towards the achievement of universal healthcare coverage as encapsulated in National Healthcare Acts and in tandem with sustainable development. In short, I'm writing a paper this afternoon before I even opened this to see on sustainable development goals 3. And the interesting thing about the sustainable development goal 3 is that it comprises everything about primary health care, prevention of unnecessary suffering due to diseases that we could actually prevent, increasing access to funds, improve government funding, evaluation of processes. And they were asking us in that particular course, what do you think government should have done and should have developed in the SDG 3? And 2 things came to my mind. I told them the first one was the mental health of healthcare workers. Nobody talks about it. Of all the things, it was focused on the patient, mainly patient. I think I even have to note it down. Mainly patient-oriented. Every single policy was about the patient, Nobody thought about the healthcare worker, the impact the healthcare policy. And then some studies were done to show the impact that some of the studies and some of what we've done is actually affecting the healthcare worker. The second one was nobody envisioned there was going to be a global pandemic, a global health emergency. Example, COVID-19. We are all focused on global pandemics like HIV, like TB, malaria. Nobody saw COVID coming. So immediately it came, everything shut down. And so people keep asking, what happened? Why is it that, we're all following the SDG goals, malaria, TB, HIV, and the rest. And then COVID came. And all of a sudden, we produced a vaccine. The reason was when the SDG goals, which was a successor of the Millennium Development Goals, was formed, nobody envisioned there was going to be a global health pandemic. And not even on the scale of COVID, killing millions of people. So everything was shut down and all attention moved to COVID. So then they asked, what was developed and what wasn't developed? The first thing I said is, mental health of healthcare workers And I'm going to read through whatever we're writing. Mental health care, so you can drop your comments out. Mental health care of healthcare workers, mental health of healthcare workers, and the fact that nobody was preparing for a global emergency pandemic. So, and what was the overall policy goal? To strengthen Nigeria's healthcare system. That was it, in such a way that there is quality, that is effective, efficient. I always tell people there's a difference between something that is effective and something that is efficient. If I get a knife, maybe not knife. Let's say I want to kill a housefly, right? And then I just spray insecticides here. It's efficient. It means I'm achieving so much because if in spraying the face, I'll kill the housefly, kill mosquito, kill a lot of things, right? It becomes efficient. But I want to kill a housefly, get a sledgehammer, like we say, and hit the housefly. First, you destroy the floor, you kill the housefly, and you may even wound yourself in the process. It is effective, but it's not efficient. In efficiency, you get so many results with so little. That's efficiency. Effective, they are not the same. So you can look up those two words. Then equitable, that what was given to the senator in Abuja is the same thing that is given to me that is staying somewhere inside the bushes of Nigeria. Is it accessible? Can I wake up and cross over the fence, enter the primary healthcare center close to me and fight Kef trials out there? No, they'll tell you there is no drugs here. Sure, they don't even have paracetamol. Bata, you will see GV, tension violet, cotton wool, and an expired paracetamol, and probably some rusted discs. And that is where many of us are going to work when we graduate. Funny. And is it affordable? I don't know if I'm still being heard.
We can hear you, sir.
Yes, sir.
Yeah. So is it
I can hear you,
affordable?
sir.
So in as much as it's affordable, is it acceptable? And does it give comprehensive healthcare service? You know, we've abused the tertiary institutions so much in Nigeria that we think it is the norm. Cases like malaria, and that's why if you look at the medical school curriculum, which may explain some of the things, the medical school's curriculum is structured in such a way that it looks at comprehensive healthcare access at clinical postings. Let me give you an example. Tertiary institutions should not handle what we call primary diseases, or so we speak, something that a GP could handle. Abroad, like NHS in UK has it very well. US, where they have a lot of out-of-paid pocket expense, very expensive. But then UK has a program you could look at and say, okay, this can handle it. See, if something, malaria, fever, vomiting, these things should be handled at primary healthcare centers. Trained people, GPs, sitting down there morning, afternoon, night, handling these cases. But what do we see? The tertiary institutions should be institutions of research, policy formulation process. So when you look at the medical school curriculum, you'll see that by the time you get to, let's say, 4th year, and you start going for ward postings, visiting the clinic, clerking patients, you're meeting cases like heart failure, kidney failure. These things should actually be secondary. But if talking of dialysis, policy formulation, those are tertiary. But then we are seeing these things appearing in tertiary institutions. And we just have people that know what to do, but they don't even have enough. They're not even equipped. Short, we see CT scan, everybody is jumping up. CT scan should be in a primary healthcare center, for God's sake. It should not be something that when we see, we make adverts, do ceremonies, snap pictures, post it everywhere and say we have a CT scan. By the way, it's not even the latest CT scan. And that's the problem. So the curriculum should be that way. And then when you get to 5th year after this and you start doing your community medicine posting at 5th year, they tell you to go back to the villages, primary healthcare centers, butchers, markets, so you can get to the grassroots and see what is going on there. You start getting involved with primary healthcare center, ministries, government, because these are the grassroots implementation. Then after you finish that posting, you come back again to medicine and surgery and meet the bigger cases again and take your exams. And you have, during community medicine postings or primary healthcare postings, see that you have to write a project, knowledge, attitude of so and so. What is the impact of vaccination also? I don't know if some of us are beginning to understand some of why the postings are structured this way.
Yes,
sir.
sir.
Yeah. So it will make a lot of sense to you now why the medical curriculum is that way. Now, I'll go forward to just talk about our WHO. Just tell me once we start taking a lot. I think I have maybe a little more time to go, but I'm taking time to explain these first aspects of this slide. Now, when we look at our WHO building blocks, anybody that have heard me speak, we see that I've spoken about this. Short, during some of my modules in master's program, I had to tell them that if you want to even adopt any policy, you must make sure the policy fits into the WHO 6 building blocks. You can evolve, you can adopt it, you can rearrange it, but everything seems to happen among these 6 building blocks. Somebody is writing again, and is this my particular friend? The first one is about leadership and governance, which is the first one here. I don't know if anybody's seen my mouse, my cursor.
Yes.
Good.
Yes,
First one
sir.
is leadership and governance. Do we have administrators, policymakers that are looking at what we are doing? Okay. Do we have somebody there that is directing things? The second one is information, health information management, health information for health. All right. So this health information, where do we store our information? How do we get it? Mortality review, maternal and child mortality, number of infant births, number of incidence ratios of HIV. These are data. This is where we need them. There should be a data unit in every hospital. How many admissions have we had and how many deaths have we had because of malaria? How many children came in because of malaria? How many of them were discharged? How many of them stayed for 2 days? How many of them stayed for? We need this data. Without data, you cannot formulate policies. Third one is health financing. It is recommended that 15% of the funny thing is that this meeting was held in Nigeria by all African states, and the agreement was 15% of our budget should go to health. And I can tell you, Nigeria has not done even up to 5%. Meanwhile, the meeting was held in our own backyard. We signed it, we hosted them. We told them it's good, everybody adopted it, yet we did not do anything about ours. Besides financing, where also are we financing most of these things? Are we paying healthcare workers on time? You should answer that question. Training of the healthcare workers, both skilled and unskilled, that includes doctors, nurses, professionals, healthcare, traditional birth care attendants. They need to be trained. We need to bring money to train them and make sure that those guys are paid as at and when due. When they come to the hospital, do they have adequate money being pumped into the healthcare to meet the financial obligations? The fourth one is service delivery. How efficient is our service delivery? Do somebody have to wait for 10 months to see a consultant? Do they have to spend hours to see one consultant? Do they have to spend hours to get a receipt? So the reason some people even go to private hospital is service delivery. But even now, the private hospitals don't even offer the kind of service delivery we want and we say is acceptable level of service delivery. Now, human resources. This is where it's going to hit Nigeria. And I'll start by saying that we don't even have enough healthcare workers. Each state, the last data that was released by NMA, I always keep forgetting to bring in that slide each time I talk to medical students. It's estimated that each of the states, besides Lagos, has less than 2,000, not 2,000, less than 2,000, at least from 1,800 down, of medical doctors, of which almost 80 to 90% is concentrated in the urban areas. That's why we have influx of quacks, chews running around in our villages. And our mothers and fathers patronize them. Even though we are doctors, we are not there. If he's sick, he goes to a quack and say, mix drugs for me. They will mix a lot of things and give them and they take. Because we don't even have enough human resources. And then the second one was discussing with my friend, and I told him, you know, the funny thing that's going to happen in the UK. He said, no. I said, in the next 5 to 6 years, which even the UK is beginning to talk about, that Nigeria may seem to be the answer to the shortage of manpower in healthcare, because we even train people for less than 1% of what is trained doctors all over the world. So he said, one day, if you're meeting any black person, if you meet 4 black people or 4 Nigerians, 3 of them will have a UK passport. And if you check the three, two of them are going to be doctors or healthcare workers. I said it's going to happen, I'm very sure. Because the way people are hearing doctors are moving, nobody has even talked about the way nurses are moving. I don't know if anybody have seen where they poured water. That's how they are moving. Quietly, neatly. Some people don't even write exams. Some, like radiograph, they don't even write, they just submit that they trained in Nigeria, is accredited, and they're taking. For us, some of us have to write PLAB 1, PLAB 2, PLAB 8. You finish, you come and look for a job again, do interviews before you're taken. So in the next 6 years, this is going to happen. Not just about that. We're also having less people coming to study medicine in Nigeria. Even Nigerians themselves are not studying medicine anymore. It's started abroad and it's coming down here. Reason, there are other occupations that are paying more. So I know I left clinical practice like 3-4 years ago. I've really not practiced clinical medicine. I've been into data analysis for policy, organizational structure, and the rest. But I can tell you that there are people like me scattered all around different organizations offering technical assistance, and they are not doing anything very close to seeing a patient. Some eventually see patients in their spare time, but it's not their core responsibility. Begs the question, who is actually seeing these patients? Nobody. And we're school is on strike, and we're trying to see how to push medical students to graduate, and we're still having a gap in human resources. Some hospitals now are begging people to come for residency. This was a very competitive post like 5 years ago, but nobody even wants to do residency. Why would I have to put myself through all those stress for 6 years only to be owed salaries and paid poorly with insult and a lot of work burden? So nobody wants to do that. Now, medicine, technology, and vaccines. When people come to hospital, do they have the CT scan? Do they have enough drugs? Do they have the vaccines if they want to take COVID or malaria vaccine or HPV or cervical cancer vaccines for females? Are they available when they come? So all these things are patient-centered healthcare. And the idea is that the 6 building blocks should look at strategic vision policy design. You should look at addressing corruption, right? Being transparent, being accountable, and participation and consensus orientation. If we don't have this happening, then this may not be happening everywhere. Another thing we'll have to look at is monitoring and evaluation of policies. This was how our policy was supposed to be. So they've done the policy. They have strategies to look at its national health strategic health development plans, which was going to happen at both the federal, the state, and the local government level. Now we also allocate resources at all levels, midterm expenditure. I don't know who is screeching on the screen. Somebody's drawing on the screen again. Then priority activities. I think somebody's mic is on too. So just check if your mic is on. You could help us by muting. Okay. So medium-term expenditure frameworks and then annual work plans and performance monitoring. I do this almost all the time. There is no time we don't sit down to look at our frameworks and performance monitoring. You write all these indicators. All of them stem from policy. So see how it moves from policy, like remember policy, then you formulate strategies to take action, then you allocate resources to move them, and they have to be different for federal strategy, both federal, state, and local governments. Then you prioritize activities based on the resources. You have an annual work plan for implementation, and then you monitor and evaluate, like I said. This was also done for Nigeria, so it's not like it's different. But let's critically look at some of the healthcare indices. So we are going to examine between 3 years, from 2003 to 2013. That's a 10-year data. We still have an upgraded one, which probably maybe later we could just look at it. With the number of lines being drawn on my screen by this, my friend, which I don't want to call their names, and her name is still appearing on this screen. I don't know which of the lines I'm following. I don't know whether it is the red line on my own map or it's the line she's drawing. Okay. So the indicator we are looking at is trends in child mortality and live births, right? So where we are looking at this mortality rates is actually done by 1,000 live births. So we know who neonates are within the first 7 days of life, infants less than 5 years, postnatal mortality, child mortality, and under 5. So this is the index that we are looking at. We still have a huge number of these people. As of 2008, we still have 545 people, children that are dying. this is still increasing, even though there is a slight decline, but we cannot say there is much difference happening between 2003 to 2013. There may be almost 50% decline in 2008, but between 2008 and 2013, nothing much has actually happened. And it seems that we have more of the deaths occurring at under 5 mortality. So those that eventually survive after the first 7 days of life, we eventually see some of them dying before their 5th birthday. And that's very sad. We still have a lot of children dying from causes that we should be preventable. Just imagine, child mortality is still 112 as of 2003, came down to 88. This is per 1,000. So multiply this by population of almost 200 million. You get to see what I'm talking about. So when they say per 1,000, doesn't mean only 88 children died. No, is that if you divide this 100,000 by our population and multiply it by this, that will give you the exact figure of what we are dealing with. So 112 children to still 64, that's still a lot of numbers. And it's heartbreaking. These are people that are dying. So if you look at our general expenditure, like I talked about in health financing, compared to what other regions are spending, you'll see that Nigeria is spending far less. This is where we are. Far less compared to what the region is spending. 2.5, we are less than 1.5 per capita. Look at our proportion of capital expenditure. We are still below every other regional expenses. Oh Lord, who is doing this? So when we look at, take a look again at the summary profile of our healthcare workers. Remember what I told you. It seems as if it's even getting worse. This is sub-Saharan Africa, right? 15. Nigeria seems to have a lot. Maybe that's why we're exporting, but it's still very, so for medical doctors, 38 people per 100,000. So let's even make it 50. Remember what I told you about each state having a size Lagos that has 4,000, less than 2,000 of doctors. Look at nurses, 148. I think they have the largest number. This is what we are looking at. Look at pharmacists, 10 per 100,000. So we are still substituting with community healthcare worker choose, who we find almost in all our primary healthcare centers, community healthcare workers. So these are people that we trained. Look at radiographers, 1,286. And many of them have left. Med lab scientists seem to have the highest after nurses. And see, just 11 physiotherapists. So even if we have people or loved ones that are suffering from cancer or have cancer, suffering from accidents that needs chemotherapy, we don't even have enough people to help them with the physiotherapy that they need. So look at our primary healthcare centers. Remember what I told you about leadership and governance and infrastructure. So we have 21,808 as at the time we checked this report in 2011, 21,000 primary healthcare centers, 969 secondary, and only 73 tertiary healthcare centers. Then that number is being helped and substituted by the private healthcare sector, about 8,290, followed closely by secondary that are still private, maybe the religious bodies that are owned by churches, big churches and Orthodox churches, and then tertiary institutions are like 10. So on the whole, we just have 34,000 hospitals for a population of 200 million people. More than 200 million. So you see, we don't even have enough facilities to take care of our healthcare needs. So in conclusion, this was adopted from a national healthcare report. So while medium and low-income countries have been able to provide social and financial risk protection for poor people and vulnerable population, I think this is what we need to do in Nigeria. Okay, and we need to take and adopt schemes and implement policies that are targeted to the vulnerable and the poor, because they seem to be the 95% of people who need more access to healthcare. Let's also remember that diseases are usually found in the lower socioeconomic groups. Of course, they're still classified as a country, as people who are below the poverty line. In short, it's getting worse when you look at our GDP, which has fallen from about 6% from President Olusegun Obasanjo's time in 1999 to less than 0.81% now that Buhari is head of state. So that's almost 6% knocked off in our GDP. So it's going to get worse. And that will explain the lot of arrests, incidents in crime, and a lot of deaths we've been witnessing. And because people are becoming impoverished, we have failure to obtain much needed healthcare services. So government must find a way to reduce out-of-pocket expenses by funding the healthcare NHS. Do a lot of this and implement an account, make sure that people are held accountable for the monies that are being sent into those places, and adopt the right taxation. You see, when we adopt the right tax, some people walk away with, some people don't even pay tax at all in this country, yet they're the ones that are way more. That why is it not working? If you've lived in somewhere like UK, you realize that everything is taxed. You say good morning to somebody, they tax you. You're walking around, they tax you. You pack a card, everybody just takes the train. Nobody has money. You buy a television, there is tax. Even now, some of us that buy from big supermarkets, we see that when you take pay and you look at your bill, you see that something you bought for 1,000 naira, you realize maybe the price is actually 920 naira, but then tax is 8,000. So I took a boat when I went to Lagos. And when I printed I just said, let me have a look at my receipt. I saw that almost 20% of what I paid for was taxed to the Lagos state government. It was so funny. But they have a way of adopting this taxation that are channeled to some of the social health care, free education, health, and health, formulating policies and making sure that these things run. So I'm going to stop here, and what some other things you do, we can discuss them. Thank you. I think I've really taken a lot of time. Thank you so much.
Thank you so much, sir, for this session. So I think it's time for questions and answers. So if you have any questions, you can raise up your hands. Please, who has a question? Raise up your hands if you have any.
So you can raise up, or they can just unmute themselves and just go ahead. You could look out for people that raised. I think somebody raised her hand while I was presenting. So just look at it. Yeah.
I think we have one question in the chat box.
Okay, I'm just trying to read down.
Good afternoon.
Yeah, go ahead.
Okay, I have a question. I was seeing the process by which policies can be implemented to maybe improve the healthcare system. And sometimes the problem is usually implementation. Are there any methods that can be used to check this implementation and maybe just improve the healthcare system?
Okay, so I think implementation, like you said, it has always been our Achilles heel in Nigeria. And I think one of the things about implementation is the will on the part of the leadership of whatever institution it is to implement it. I'll give you an example, like the Universal Health Coverage Bill and Healthcare Act that says we have to have at least 15% of our budget implemented. Yes, it's been written, everybody accepts it, but which president has looked at it to take responsibility to make sure that at least 15% of our budget goes to funding? It will shock you that 15% of almost 80% of our overhead costs, which comes from borrowing actually from countries like China, India, and the rest, is being fueled to pay salaries. That's even how bad it is. So other social reforms like education, healthcare, are left to the caprices of whoever can pay for it, or the highest bidder, or private practitioners. So government will and political will on the part of the government is one of the ways. But I think the most effective way that we could have done that is when we have a bottom, like one of the professors in Oxford University explained during our course. He said, one of the things we can do that is most effective is to have a bottom to top approach, right? And the bottom to top approach is when the people themselves start demanding and asking for some of these things to be implemented. So we have a duty to make such awareness to be heard for everybody who to the citizens to actually know that this is available, right? When we've now made that available and we've made a lot of sensitization, had town hall consultations, town hall meetings about it, then the people can demand that this should happen. When a group of people stand demanding and people actually go all out and say, see, we need this to be available, then we start demanding for these things to be available, they will start being available. I'll give you another example. There's this wind of political change that is happening right now in Nigeria, and I think everybody is feeling it. You see, previously in the last 8 years, nobody was actually asking about PVC. People just say, well, politicians should go and do their thing. But all of a sudden, Nigerians are seeing that the dynamics can actually change if we all come out. And I can start with the SCOPI movement when they did the NiMSA. People, oh, this is very powerful, right? Now everybody is all advocacy. Some celebrities have come out asking for it, saying people should go and get their PVC. People are organizing concerts, and for you to come, you have to bring your PVC. So these are encouraging people to go all out, and INEC cannot meet the demand. And so they're saying there are 50 million Nigerians who want this but can't even afford it, and we have less staff, and they're prioritizing some states. So imagine if we have this kind of huge amount of awareness being created for implementation of healthcare policies. Imagine people demanding that this should be here, CT scan should be here, MRI should be here. They are tweeting it everywhere. They are having town hall meetings. They are having debates. Channels are carrying it all the news channels are talking about it. So the bottom to top approach starts happening. If you're coming for election, we'll ask you, how many CT scans have you brought for us? Are they working? How many people have used it? Have you employed people? They ask you these critical questions. And if you cannot answer, nobody votes for you. So I think one of the most effective way we should do this is from that bottom to top approach. And if once you do that, I think we'll have it. Yeah. Don't worry, you'll get the slides. Yeah, go ahead, Fatima. I think your hand was raised. Fatima Olayinka.
Good afternoon, sir.
Well done, good afternoon.
Thank you very much for the great session. You talked about the bottom to top approach. That was actually the first question I wanted to ask, but I thought I should chip this in first. We all know that it takes a lot of influence to get people to believe in what we believe in. Either our belief is wrong or right. And Nigerians are actually really skeptical, or let me say remote group of people who might not see the bigger picture when you try to sell an opinion or a better option to them. So if we are trying to make sure that there is an adoption of the bottom to top approach, but there are no effective methods to make people believe in to make people believe that it would be a positive way to getting better things, maybe in terms of healthcare or transportation or any other way of, or any other means of adopting it. Is it possible to get like a lay down system to make people be involved in all of these things? Doctors can't do these things alone. Medical students can't. My question is, how can we make the bottom to top approach adoptable? How can we make people believe that it is a way to make things work?
Okay, thank you so much for asking that question. For us in public health, it's really not something that is new. And I'll tell you why I'll say it's not something new. So when the vaccines came in initially, and people were asked to take vaccines, and people did not take the vaccines. They were like, nobody is dying. Some people were reading some of fake news. If you take it, you become sterile. If you take it, you will die. There were people releasing data about how lime water and salt will do the thing, or about how some people who took it had cardiac problems. But after investigation, some people saw, well, these things weren't actually related, maybe in a small sample of the population, but in the huge population, it didn't happen. But one of the things that was interesting as days went by was we now realized that there are some strategies that we are worldwide that we are working. For example, I'll tell you two, which I've mentioned one. The first one was wide consultation with stakeholders, right? If you get people, traditional rulers, religious rulers, prominent people, and get them to speak for the vaccine and the reason why we have to take this advocacy, people listen to them. People listen to their spiritual leaders, people listen to their pastors, listen to their politicians. There are people that wield influence in these places. Those are number one. Those are one of the things we did. So we held a meeting together with the US ambassador, got all these people into one room, allowed them to ask their questions, because we know if they can ask their questions and we answer them, invariably the subjects are going to answer us and follow us. That was one. The second thing we did was use of influencers. And these things have been done in the United States. So I know in Imo State, because I was heading the team here for the HIV clinical mentorship program, one of the most effective things that happened when we did this in Imo State was, I don't know if some of us know Cubana Chief Priest that owns a club.
Yes, sir.
So we got Cubana Chief Priest to come and take the vaccine, and it was televised everywhere. And we saw a surge in numbers and number of young people that were coming to take the vaccines. We got celebrities to come and do shows. In short, Cubana Chief Priest organized a show. And in that show, we leveraged on the show and had a vaccination booth. We vaccinated nothing less than 2,000 to 3,000 people that day, just because of that show. So imagine healthcare policies. Celebrities are just like they're being for PVCs. We start using celebrities to influence, or so-called influencers, both on Facebook, and celebrities. They organize, and when they come, they start talking about, I now have my national health insurance card. How many of you have your national health insurance card? If you don't have it, you cannot come for my concert. Imagine Davido saying the only thing to come to my concert is to have your PVC or your health insurance card. Of course you will come. People will come. So these were the two strategies that were very effective, especially when we looked at the target audience. For the older audience, it was their religious leaders, political leaders, people they respect coming to ask their questions, and we cleared the doubts. They were like, oh, we didn't even know it was this way. We told them the myths, removed the myths, and told them the facts. And then for the younger population, we used the influencers. We tried to use the social media. These are strategies that worked. And then we visited places of worship, places where people shop rights, big shopping malls, markets. These are places we went to. So when you sing this thing into people's ear, we even did a jingle in different languages: Broken, Pidgin English, Igbo, Yoruba, Hausa, even Ishekiri, Idoma, Tif. We did these things in these different languages to make sure people come. So these are one of the ways the bottom approach can work. And I can tell you the bottom approach is everything. It is everything. Nothing makes political leaders move than when their subjects threaten them with not coming back for re-election if you don't provide for something. I think that was just stop for the question. So I think I was going through, I don't know if does that answer your question, Fatima? I think your hand is still up. I don't know if that answers your question.
Yeah, it does. Thank you very much.
Okay, so somebody was asking.
The second question.
Yes, please go ahead.
Okay, you were talking about the consensus adoption of 50% budget for healthcare.
15 actually, 15.
Yes.
15, yeah.
Yes, I don't know if it's just African countries or all over the world, but
I think it's mainly, it was mainly for African countries. Yeah. So somebody asked, asked, go ahead. I think where you are is so
okay. So now that you have said that the Nigeria government barely allocates 5% to healthcare, despite the fact that there is a laid down guideline for 15 to be allocated to it. And this has been occurring over a number of years. I think I don't know if I'm right or this is a fact, but it is just common sense that when things happen over time, there'll be a point where marginal factors come into being. So if this trend of allocating 5% or lower than 5% continues for, let's say, over the next 10 years, what do you think, or where do you think Nigeria healthcare would be? For example, most people, like most medical students, that's like a general thing, always work towards migration after graduation. And this is because the work environment and ethic is not that, I don't know how to put it, it's not that alluring or benefiting for us here in Nigeria. So if there is a case of little funding for healthcare and little availability of healthcare providers, do you think, absolutely, Nigeria healthcare will be in shambles, but do you think that it would be so worse that there'll be a situation whereby none of the healthcare, I don't know how to put it, pardon me, none of the healthcare services will be available for people irrespective of their financial capability, either rich or poor, except they get it for like a private or outside source? I hope you understand my question.
Yes, I get where you're going to, but first of all, let me go from you mentioned 3 points. The first was implementation of the 15%, whether it's general. Well, it's actually for mostly African countries, because it was something that everybody in Africa came together and decided they were going to do, and the meeting was held in Nigeria. Now, let me explain how that works. And I think the second point you also noted was about if this is going to affect our healthcare, right? And then the third one is even if you have money, will you be able to pay for it? My dear, I will tell you it is already happening. There were a lot of rich people that died because there were no ambulance services to ferry them from where they were to maybe I think somebody's mic is still on. So there are a lot of people that had, some rich people we know personally, it was also in the news, that had money. The money came in, they have a lot of money to provide and pay, but they could not pay. Before the ambulance services could come to take them because they had a heart attack or they have a medical emergency, they died. But that family, if they were in a place where there was universal healthcare and access to effective and efficient healthcare, that man would have survived, whether he had money or not. It's even a question of access. It's not even a question of do they have the means. They have the means, but they couldn't even access the effective and the best healthcare. So yes, it's happening already that you have money and you can't even. I also tell you something else. I had a personal relative that needed to be treated. And all the doctors I called that were in my class, 3 of them told me they've left Nigeria. I didn't know. I just sent a message on WhatsApp. Please, if you're around, help me. So I'm not in Nigeria anymore. When did you leave? I left last month. When did you leave? I left last week. The one said he's at the airport now. You leave by 12 midnight. And I was, what? You mean I can't even have people look at my own people? I said, yes, I'm not around. So even us doctors are being, so somebody wrote something that if you leave Nigeria, you still have siblings and parents and loved ones here that won't even get the best health care when it arises. Some of us have been in the hospital and we see people abroad making phone calls, calling, saying, please, my son was the one that was admitted, or my sister was admitted. Please, what do you want? Please, what are you guys doing? Why are you guys not giving this? Man, we don't even have it. We know we are supposed to give it, but we are using what we have. And they are worried. They'll start saying, Nigeria is this, Nigeria is that. Well, you were here before you left. But these are issues, okay? They are very, very important issues. Now, is it affecting healthcare? Yes, because some of the private healthcare workers don't even offer what they're supposed to be offered. And they are driving home profits. They want to make profits while selling fake drugs. So something that is sold for 15 naira, they sell it for 500 naira, and you're buying fake. That's how bad it is. So you can buy, maybe before you need to give somebody 50 milligrams of ceftriaxone to get the person to get well, and you're giving almost 150 because what you have, the quality of the drugs, that's why the emphasis, the quality of drugs is not even assured. That's why the emphasis is on effective, efficient, and safe medical technologies and vaccine. So the drugs we are even giving people, even if we know what we are supposed to do, is it even safe? It's not. It's that painful. And the last one is about policy 15% and 5%. Let me explain. When they write budgets, the budget has the 15%. When you get our healthcare budget, it has it because it must have it before it could be passed. The problem now is how do we finance it and implement it? Remember, part of the implementation is financing. But how do we finance this and implement it? We don't have the money in our foreign reserve, so we have to go borrowing. And we have what they call running cost and overhead cost. So let's say they give you pocket money, 10K every month from oil revenue, your parents. So use your parents as oil revenue from the federal government, and you are the state government getting these allocations. They give you 10,000 naira, so to speak. And I'm just trying to use a figure that everybody can relate with. So they give you 10,000 naira, but you have what is called running cost. What's the running cost? You have to eat, you have to fetch water, you have to have water to use. So food, clothing, shelter, you have handouts. And then there is these infrastructures you have to put money into. There is unexpected expenses, like they wake up and say, SUG dues, or your class is going for excursion, and you need to go with them because it's very important. Those are unexpected dues you have to pay. You have things like data, water, food. These are running costs. These are things you must do every day. Salaries, those are what the government terms running costs. But we now have to look at things you have to push funding to. And we are saying 15% of it should come. So by the time you've done all your running costs, you realize that what you have is minus 2K. What minus 2K means you borrowed 2,000 naira from your friend to make up for the 10K. So that's like Nigeria borrowing from India or China to make up for it. So by the time you look at, oh, you've done your running costs, you've done everything, there is no money actually left to now fund things like buying a new school uniform, buying a new shoe, changing your trouser, getting a new singlet, or this, like, oh man, nobody's seen my singlet. Let me wash the one I have neat and wear it. I'm trying to use something that you can relate to understand what I mean by running costs and the place. So by the time we are done spending money on running costs, nothing is remaining again for us to run some of the things we need to do. That is where. So, but even if we finally do it out of emergency, or emergency fund out of emergency, we realize that it is not even up to 5%. Most of the time when you check the data, that is what is meant by that sentence. So,
okay, so
I think, yeah, go ahead, Esther.
So if you're aware of this money, like
Please,
the money,
I would like to cut in now. We don't have so much time, please. I think we can keep your questions for now, and
just put them on the chat box. Just put them on the chat box. I'll just make a general answer.
Then there are some questions in the chat box that have not been answered. I think we'll just go ahead with those ones before we close now.
Okay. Let me just run through them. So somebody said, when it comes to out-of-pocket expenses, will this require a policy or just advocating? I think advocating will do more. Even then, when we advocate and they accept it, remember the processes of advocation, then you can have a policy not to encourage. Actually, nobody should actually spend out of pocket for some things. Even if you're spending, should be at a subsidized rate. Then what's the role of health doctor and healthcare physician in policy implementation? Where does the doctor come in? Everything from when we are engaging throughout, the doctor should bring problems to the forefront because we're actually the food soldiers. So if you have a problem you encounter in the clinic, like long waiting time before the food that gets from you to from the nurses to your station, it takes almost an hour. Meanwhile, patient has been waiting. So you have to talk about the problem. You talk with the management, they formulate a policy, tell them and advocate what you think can be done to improve it. And sometimes policy means you have to sit down with the nurses, the porter, the healthcare records people, and formulate something or a process that works, and it becomes a policy. So the doctor has so many roles and every single role to play in implementation because we see the patients firsthand. We understand all the problems that are going on with them. So when we identify those problems and solve them, they become a policy. Somebody said, in the course of evaluation, do you need to modify a policy document that has been passed into law to suit new realities? Yes, sometimes some of these things can be reversed. That's why after laws have been passed, the Senate can call for a revision or modification to that law. You can see some addendum that will say, yes, people should not come back by 10 p.m. However, you now start seeing things like, in case of emergency, when there is an urgent need or extenuating circumstances, when there is, so you start seeing all those things being put in place. So the current reality, like COVID-19, initially, everybody was required not to wear mask, but now you have to wear mask everywhere because you need to protect yourself and other people. However, some policies are saying relax it on masks, except if we are in an enclosed environment. But if you're outside, nobody is required to wear masks. These things are policies because they are now current realities. And some laws actually evolve. That's why they say the laws were not made, man was not made for laws. Laws were made for man. So when the circumstances change, people change with the laws. Trying to run down. Okay, so how do we get government to acknowledge and implement these policies? Like I said, the bottom-to-top approach. And what do you mean by efficacy and effectiveness? I don't know how else to explain this, but I think I gave an example of using insecticide and trying to use a sledgehammer to do some things. So you could also Google it. It will make a whole lot of sense to you. Efficiency is actually trying to do, so having something that does less, achieve something with less. Okay, let's say you want to send money to your friend, right? And you have to go to the bank, queue up, collect teller, fill your form, put it, then they make a debit on your account. It is effective. But if you can sit down, just open your mobile app and click 1, 2, 3, 4, and the person gets the money in an instant. Sometimes even that money you paid in the bank may take like 2 working days to be processed and get to the person. But if you have an online platform where you just open up your this and click, so that's going to the bank is effective, is an effective way, right? But using your bank app becomes efficient because you achieve and save less time and still achieve the same results, even in a shorter time. And it's faster, it is sweet. That's what, so when you hear efficient, you start looking at speed and results. Okay. What do you mean by out-of-pocket expenses? Out-of-pocket is, so some people happen to be on, let's say, use scholarship for an example. You're attending school, but then you realize some of your mates that are coming from particular state or countries don't pay for a service with their own personal funds. But you have to pay from your personal. So paying from your personal funds is out of pocket. But if you don't need to pay, then it becomes that this is subsidized. So it becomes health insurance is an example of not paying out of pocket. But paying out of pocket is go to a hospital like private hospital, and that hospital does not have you linked on the insurance scheme. You have to pay for those services from your personal fund. That is out of pocket expenses. Yes, efficiency is getting the most results for the least effort, basically. You can say that again, Oji. Thank you so much. So I think I've cleared the questions I have in the chat box. And yes, personally, I have 2 more minutes to stay because I'm also writing a paper on STG3, like I said. Maybe if you have any other questions, they could send it and route it to me. I'll answer them if need be. So I think this is where we could stop. I'll hand over to the moderator to continue. Thank you so much. I think we spent like almost an hour and
Thank you so much for this session. Like it was so enlightening. So you can share your contacts in the chat box. So anybody that wants to contact you can just contact you for any more questions. We won't take any question from now. And also the slides will be available for those asking. And the recordings will also be available. It's even streamed on YouTube, so it's not an issue. The recording is not an issue. You can go on YouTube to check it, or you can just get it. And then I think that's also, and I would like to just pass some few announcements. I've marked the coursework 1A. Please check it. Most of you have not checked it. Please check for the corrections I made. The corrections, you see that I highlighted some words. So you click on the words I highlighted and you see the comment I made on them, so that when you are writing it next time, you correct it. Then another important announcement, please, if you have any issue, please, before the end of today, all issues must be cleared, like every issue. So if you have issue, your group, you are not seeing your group name, you are not seeing your name, you have not seen your name on the list, you have any issue that you have, any issue, or maybe, or maybe you are not, I would say maybe you are not enjoying the session or you didn't attend the session or anything. Please, any issue that you have, your name is on the list, second phase, or you have not seen your coursework because I've released the result. You have not seen your coursework. The 1A, the coursework 2, it's not yet ready, but coursework 3 is ready, and 1 is also ready. 1A is also ready. Please, if you have not seen it or you have an issue with it, please, it should be rectified. I don't want to share a group and share topics and somebody's telling me something about groups or any other thing again. We don't have time for that anymore after that. So please check your groupings. If you are not okay with your group, you can tell me, I'll change it. You don't like the group, you go to another one, just let me know. Please, every issue must be rectified before the end of today. Nobody should tell me that Nobody should be telling me about anything again, any issue after today. Like tomorrow morning, somebody's telling me that he didn't see his name somewhere or anything. Please, I don't want to receive any complaint again. Please sign out before we close. I think it's exactly 3:30 now, so we'll be ending this meeting now.
Hello. Sorry, I was supposed to have done this earlier so I could sign out too with everybody. Just a quick one. Like I said, after each session, where I'm come from, we actually ask for feedback, what I could do, what I didn't do well, and what we hope to improve on. So I just wanted to get maybe like 2 or 3 people to tell me give me feedback. How was the session? What do you think I could do to improve the session subsequently? It's just for my own personal purpose. So I want to maybe just unmute yourself, maybe just 15 seconds each. I could just, yeah, Helen, please go ahead.
All right, thank you very much for the session. I think you engaged us and it was really good. I love how you put examples and all of that. That's a good one for me, and I want to see well done.
Okay, thank you so much. I think somebody else was up. I think Fatima. I think your mic is on because Fatima Olayinka. So
The session was great, but you could invest more in graphics and pictures for next classes.
Okay, that's okay. Yeah, I am considering the best time and the shortest time. I think you have to note your mind. Yeah, that's noted too. I really wanted to put in more pictures, infographics, but I also felt, well, how best to, it's supposed to be an interactive session. I felt if I put so much pictures, it may distract us from it, but that's noted. I'll have to look for a picture that relates solely on the topic. And please forgive me, I had a short time to prepare for this slide, very, very short time, because of something I had, I had to be reminded almost like every 2 hours that I have a session to prepare for this. So subsequently, I'll devote more time to improve the learning experience. But I hope to do more narratives with it, which for me is more important. Thank you so much for that feedback, Fatima. It was well noted. I'll do that. Thank you, Victor. Thank you, Chiamaka. Arguably the best session. Okay, you guys are now using Savlon and Spirit on my head. But that's okay. That's fine. I'll savor it while it lasts. All right. Thank you so much. So I dropped my phone number. That is also my WhatsApp number. I also put in my LinkedIn, so you can just send me private messages. You don't need to call. Just send a message on WhatsApp. I will see the message and I will reply. Thank you so much and have a very lovely evening and a very beautiful new week ahead. I'll sign out now.
Okay, thank you so much, sir, for the session. SCOPI Academy also appreciates your efforts and everything. We appreciate you, sir. So we have come to the end of today's session.
Thank you.
3:34. So I'll be ending the meeting now. So please ensure that you sign out. I'll be closing the link by 3:35. That's in 1 minute's time. Please. Oh my God, somebody is saying he has not seen the contact. No.
I've done it. I've reposted it again. I even posted my LinkedIn and my email, so it's there. Just Google. You can just check my name on LinkedIn, SNY Emmanuel. You see it there with my profile picture. It's there. Even on still the same thing for Facebook, and so you can just send me.
You can just search him on LinkedIn. You'll see get it. So thank you so much, sir, for everything. So I would like to say goodbye to everyone. So please, I'll still say it again. Any complaint you have should be completed today, please, today. So thank you everyone for coming. Goodbye, everyone. Majesty, contact me, please, later.